Thank you, Angie. And our last presenter for this session is Professor Sharon Lewin. Professor Lewin is the director of the Peter Doherty Institute in Melbourne and will be presenting to us on HIV cure. Thank you.
Thank you, Janaki. It really is a great honour to be able to present at this fantastic symposium. I want to start by extending my condolences to Dori, Beck and Alana and the whole Kirby family and wish them a long life. In the Jewish tradition, no matter how dark things are, we always celebrate life. And yesterday was the most magnificent celebration of David's wonderful life. Before I start, I actually wanted to also convey some condolences from a number of colleagues who have asked me to make a special mention to David's family and the Kirby family. And the first from the highest levels of leadership at the Doherty and the University of Melbourne, from Peter Doherty and Jim McCluskey, the Deputy Vice-Chancellor of Research, expressed their sincere condolences. They both thought David was one of Australia's leading researchers and greatly mourn his loss. From Doherty colleagues, Stephen Kent and Damien Purcell, long-time collaborators of David, who unfortunately couldn't come here, also expressed their condolences. From Steve Wessling, the director of the South Australian Health and Medical Research Institute and previously the director of the Burnett and Dean of Medicine at Monash. Steve also expresses his condolences and great admiration for David. I should add that Steve is in fact chairing a committee for me, so he wanted to actually say that he was doing my work for me, but he would rather have been here, I think. And also a very, very special mention from the French HIV scientific community, Francois Darby, the director of the ANRS, Jean-Francois Delfraissy, the previous director of the ANRS, and Françoise Barraud-Sinoussi, who I think needs no introduction. All of them express their great condolences and their sincere sadness on David's death. And I would like to also mention that Eric Fluteau, who works for the French Embassy in Bangkok, actually came here to David's symposium to represent the French scientific community. For those of you that don't know Eric, he is wearing the most spectacular, colourful scarf and is clearly the best dressed man in the room, after Brian Gazzard, of course. And when I was thinking about saying this, I was thinking maybe I'm not allowed to say these things now in the Me Too movement, but I want you to welcome Eric to Australia. I think it's fabulous that he came out here. So I am just going to give a brief talk, and my talk is in two parts. The first is to really set the scene of why we should be talking about an HIV cure, not just to get more money from granting agencies, but why, in the era of fantastic treatment and prevention, we still need to search for a cure. And in the second part of the talk, I want to talk about David's role in translational research and cure research through the program grant that we were both members of. So 2 weeks ago, I actually went to Kampala as part of a new initiative from the International AIDS Society towards a cure initiative to start empowering and educating and training researchers and advocates in Africa around cure research. Because if we were ever to be successful with the cure for HIV, this is where it must be delivered. And we have been holding these academies, starting last year with researchers and this year with advocates, and allowing 25 of the very best advocates to come to Kampala for some intensive training on cure research. 950 people applied for these positions, so you can imagine the quality of the 25 advocates that attended. And we started talking about why a cure was important to the people that are living in the epicentre of the epidemic. And the usual things came up about stigma, around not wanting to take their tablets, around side effects, around inclusion. But strikingly, stigma was still so important, even in the era of effective antiretroviral therapy. And a cure for HIV for many of the people that were at this workshop was not around not just taking tablets, it was about being HIV negative, to not be antibody positive, which makes me realise how very far away we are towards achieving that. But one quote really stuck in my mind, and this is by Moses Supercharger. Some of you might know, he's a well-known Ugandan advocate. He wrote, "In my country, Uganda, we have access to ARVs, but every time I see Donald Trump speak, I assume he's going to cancel his commitment to PEPFAR. This would be the end of me and other people living with HIV." And although we do hear the great stories of countries increasing their funding towards antiretrovirals, it's the dependence on global funding that really leaves people so vulnerable, and I think it's something we need to be prepared for. This is the data that supports the economic reasons about why we do need to find a cure. Long-term ART has been spectacularly successful, but comes at a significant cost. And this was a model based on achieving a reduction by 90% of new infections and AIDS-related deaths by 2030, the goals of what we're all trying to do and what the UNAIDS goals are. And it shows you the total amount this is going to cost us, and yellow is the cost of ARVs alone. And you can see by 2030, the costs are around over $20 billion, with ART accounting for about 40% of it. So unless we find a sustainable way to fund this ongoing, this puts people on lifelong ART at significant risk, and for me at least, is the reason why we must continue to work for a cure. And I think it's important, though, as a researcher in cure, that we keep thinking about what a cure must look like. In the era of such amazing advances, such as single tablets, we hope soon long-acting antiretrovirals, reducing costs but significant costs of ART, and U equals U. And the Bill and Melinda Gates Foundation funded Andrew Phillips and myself and Steve Deeks and others to do a modelling project to identify what a cure should look like and what it needs to cost in order to make it cost effective in light of the predictions of what we will have for treatment and prevention. So first of all, we need a cure to be, of course, effective, leading to aviremia and the absence of ART, hopefully indefinitely, but certainly at least more than 2 years, and that early failure is potentially tolerable, but late failures must be rare, otherwise we will need to monitor people for life. Of course, we need something simple that can be oral or parenteral, administered for a limited period of time and not in a specialised tertiary care facility. The target populations, this must be effective for anyone who initiated ART at any stage and in all populations. And of course, we need a cure that has equivalent long-term safety to what we have now in ART, and the transmission risk of HIV must be zero. So the bar is actually incredibly high, even before we begin to think of whether we could possibly achieve an outcome where someone was HIV antibody negative. And based on costs in Zimbabwe, we came up with that an intervention would have to be less than $1,400 in order for it to be cost effective. So lots of hard work to do. So just very briefly, what current strategies are being tested in order to achieve an HIV cure, or what we now commonly call remission, someone that can safely stop ART and continue to have an undetectable viral load. Very simply, those strategies fall into two categories. The first is to eliminate the virus that persists on ART, either through activating the virus, or what many of you will know as shock and kill, shown up in the top, cementing the virus or locking it down or permanently silencing the virus, something now called block and lock, a feature of many retroviruses that do sometimes shut down transcription, or gene therapy, cutting out the HIV itself or making cells resistant to HIV. And there's a lot of effort at the same time in boosting immunity being done with vaccines and broadly neutralising antibodies, immunotherapy and CAR T cells. And nearly all of these strategies are now entering into clinical trials. Some are showing quite positive results. None have yet achieved a true cure or remission. But I want to talk a little bit about why we need to tackle both sides of the coin, reduce virus persistence and also boost immunity. And this study was actually just published 2 days ago. It's one of the best studies that tells us that reducing HIV alone to the smallest possible amounts will not lead to a cure. And it's particularly relevant to show because the study was done in Thailand. We heard earlier from the success of HIVNAT in so much of the clinical trial work, but Thailand are also now one of the leaders in fundamental cure research. And the work was led by Jintana and Warrenich, and it looked at what happens if you treat people within days of infection, or what we call FEBIG stage 1, so individuals who are RNA positive and not yet made antibodies. And if you put people on treatment almost immediately and continue them on treatment for 2 to 3 years and try to measure their reservoir with some of the sophisticated assays we have, you can't measure the reservoir in any of these individuals. However, when they stopped treatment, all of them rebounded with no impact at all, meaning that you can reduce your amount of virus to the tiniest possible levels and still you will rebound. So just reducing virus is not going to be sufficient. There has to be another intervention. Very similar findings have been described following bone marrow transplantation. And I show this study. There have been many of these studies, but this was done as a collaboration between Melbourne and Sydney and as part of our current program grant. And senior author was David and first author Kirsten Kolch, who was here for many years. And it basically just shows what happens after someone has a transplant for an other unrelated, of course, illness such as leukemia. This is a patient that we looked after at the Alfred. If the person is on antiretroviral therapy and you use sensitive tools to look at how much virus persists, shown there as the plus signs, you can clearly detect virus prior to transplantation. But following transplantation, virus very rapidly disappears. And this pretty much happens in all people who receive a transplant. However, in the few people that have stopped treatment, virus will rapidly rebound. So the two most effective ways that are limiting virus on treatment, very early ART, transplantation, two strategies that actually could never be implemented on a large scale, are clearly not sufficient, which is why there's such a burgeoning interest now in immunotherapy. So moving on to David's approach to research and cure, I'll start by saying that David was not a big fan of cure research. He, for a long time, did not see the value. He thought we should focus our efforts on treatment, on what we knew worked. And I think was very committed still to even with PrEP, that we need a vaccine. But I think over the last few years, he became increasingly interested in cure research. And we, as I mentioned earlier, I was part of a large program grant with David and others, which started in 2013. And when I look back at what we did a lot of, we have done a lot of very nice cure research is what I want to show some of the highlights to you. And through that program grant, I did have the pleasure of seeing David and his approach to research up close. Of course, I had worked with David in many other circumstances, but through the program grant, I really got a sense of what I thought made him so successful in research. So just very briefly, he liked simple questions and simple answers. And he didn't like complicated explanations that he used to like calling immunobabble. The minute you had 4 or 5 answers for something, he was playing on his iPad or definitely not interested. So he had a very great way of wanting to ask a simple question and get a simple answer. He actually really liked innovation. Although we heard of all the simple sort of strategies around clinical research, he loved new technologies, and he often promoted, and exactly the same way as we heard earlier, sought to see how we could apply those new technologies. He certainly liked collaboration, and we've heard lots about that over the last couple of days. And he was really the master at the elegant trial design, and I think was really just beginning to start thinking about how we might introduce some of those elegant trial designs to cure research, which is where things are moving now as we now start testing combinations. So I mentioned we've had this NHMRC program grant for the non-Australians. This is a way of how our funding agencies support groups of researchers, 5 years of funding. And it's really been a very nice collaboration between groups at the Kirby, at the Doherty Institute in Melbourne, and more recently engaging Westmead Millennium Institute here in Sydney with Sarah Palmer and Frank Caruso from Melbourne University. So one of the very nice pieces of work that's come out of our program grant comes from Miles Davenport, who's a theoretical biologist working at the Kirby Institute. And Miles has been trying to understand how quickly virus can spontaneously be released from reservoirs. And he's done that by modelling when virus comes back after you stop treatment, and how quickly it increases. In fact, the blue line that's shown here, the black line showing regular rebound. And he's developed some very sophisticated and elegant models showing that virus reactivates from latency on average about once every 5 to 8 days. And this marker is a really important tool for when we look at new interventions to see if we can disrupt this spontaneous reactivation from latency. Prior to joining the program grant, I had done a number of studies on latency reversing agents. Here showing the effects of vorinostat, a drug that can activate the virus, probably a pretty weak latency reversal agent, but one of the first that we tested in clinical trials, showing that we could activate latency, meaning that the amount of virus inside of a cell increased, but we didn't eliminate cells. And Miles, again, has done some nice mathematical modelling to understand how much virus we need to activate in order to eliminate the reservoir. And Sarah Palmer also done some nice sequencing work looking at how many of the cells we managed to activate. Damien Purcell from the program grant has developed a whole drug discovery program looking at discovering new latency reversing agents that are more potent, more specific and less toxic. He's got a very elegant strategy for drug screening, which can then be tested in patient cells, and has identified a brand new class of latency reversing agents. And more recently, with the inclusion of Frank Caruso, who's actually a biomedical engineer, we're looking at how to better deliver latency activating or latency silencing agents. And Tony Kelleher is doing some really nice work using these nanoparticles to deliver silencing agents to latently infected cells. And we're also working with Frank using gold particles to deliver similar agents. So in October of last year, we got the wonderful news that our grant was refunded for another 5 years, starting in 2019. And this is at our retreat in November of last year. David was so delighted when we were awarded that grant. David had led this grant with different teams of researchers for 15 years. This was the first time it was another leader, Stephen Kent. But I know David was really happy about this because he could see that he would continue in this very exciting area of research full of innovation going through to 2024. So it's very sad that he won't enjoy that. But we have got an innovative program all around new ways to deliver cure agents through nanoparticles, combination strategies with immunotherapy, and the effects on co-infection. And just finally, as a director of a very young institute, the Doherty Institute's only 3 years old, when I look at the Kirby and see what David achieved after building that up for 30 years, I really am truly inspired. I unfortunately don't think I'll have 30 years at the Doherty, but it is amazing. We both share a lot in our scientific strategies at the two institutes, but we also share some fantastic patrons, Michael Kirby and Peter Doherty, who you would think are very, very different High Court judge and Nobel Prize laureate, but they actually have got a lot of similarities and I think inspiring to all of us. But I think David's legacy, amongst the many other things that you've heard about today, will definitely be around national collaboration. Australia is an extraordinarily rich country of great scientists, great clinicians, great community activists, and I think together with all the many other institutes, hospitals, universities and affected communities, we can continue to do great things. Thank you.